Benny Cook. I'm from House District 143, Marys, Phelps, Texas counties. This is how, Mr. Chair, Ms. Vice Chair, all the committee, thank you very much for hearing this bill today. Great piece of legislation right here. House Bill 1561. I'm going to be very quick so we can get everybody else behind us since we have about an hour left. Just going to jump right in.
Let me stop for a second.
Yes, sir.
Because of the interest in this bill, we have, not that I want you to stop slowing down, but I want everybody else to know that we have to stop and recess at 3 because we have session. But after session, we do have this room and we can reconvene if we need to. So we'll continue as is, and if we can get it done, awesome. If we can't, we do have the room back after session.
Okay. This is House Bill 1561. This was heard last year. I believe it was healthcare reform, one of those committees. Either way, I call this a CRNA freedom bill. And I'm just going to jump right in here. I have a lot of folks behind me who want to testify on behalf, and there's some that don't like it for some reason as well. And you can listen to it if you want to. This bill leaves it up to each facility to decide if anesthesia care model. You can look at page 10 of this bill, lines 24 to 27. We still need physicians involved. Obviously, this bill is not going to take any physicians out of care of a patient. This bill is obviously, it's some common sense stuff in here that has on page 10, lines 9 through 10, mandates that CRNA cooperate with a surgeon. They're still going to work to schedule a surgery and anesthesia, and will only be provided at the request of the surgeon. This bill prohibits independent CRNA pain management and ketamine clinics. You can look on page 10 and through 11, lines 1 through 19. It also prohibits a CRNA from having prescriptive authority, page 2, lines 25 through 27. If you need to repeat any of that, I can. Again, I call this a CRNA freedom bill. It allows our CRNAs, who are not in it for the money, they're in it for the patient care, to be there in our rural hospitals for our patients and to provide that patient care when they need to be there for the surgeons and to help out with the with our hospitals in our rural areas. In Texas County Hospital and in Texas County in Houston, we have only CRNAs that are there. We do not have any anesthesiologists. I think there's a federal piece of legislation that might change that in the future. But if we depend on the federal government, then we have a lot of problems here in this body. And I know that this body is not going to wait on the federal government. We're going to take care of things here and today. And with that, Mr. Chair and committee, that is all I have. If you have any questions, I can take those now, or I can let some people behind me come and talk.
Awesome job, sir. Awesome job. Representative Roberts.
Thank you, Mr. Chair, to inquire.
Proceed.
I've been hanging around Dean too long.
Try to be an auctioneer. Call me Colonel Cook. Go ahead.
So I'm going to comment and ask this question of you, but I'm actually asking it for everybody who might come forward and talk. I have expressed to both sides of this equation, who've been in my office many times, that I am normally predisposed to agree with anything a nurse wants. I've spent many years in law enforcement, and nurses have been an important part of all of the service that we provide. There's a little bit of a challenge in this one that I'm struggling with, and I'd ask you to address it if you can. You've been in law enforcement for a while too, so you know that we have a hierarchy of command. If I had a barricaded individual, and I've got a sniper with a sight picture, and that sniper's not going to pull the trigger until I say it's okay. Because in any team concept, it sort of presupposes somebody's in charge. So I'd like to know how that fits into an emergency room. If we're going to bifurcate this authority and we're going to have physicians who are no longer in charge, who is in charge, and how do we get a team product?
I would like to leave that to if we could, the CRNAs. And I'm sure the anesthesiologists behind me would like to have some input on that. I think it would be great for them to kind of answer that because they're in there daily, and I want to make sure that you get the best answer. Okay,
well, I would invite anybody from either side to address that for me. I'd sure like to hear the answer to it.
Yeah.
Thank you.
Thank you.
Representative Mathieson. To inquire. Proceed.
Thank you, Mr. Chair. 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 T Thank you, Representative. Question I have, when we're talking about expanding the scope of practice for the CNRAs, when we're talking about, I'm hearing a lot of it in the emergency room. The rural hospitals need the help, but it feels like this bill's going way outside of the hospital setting. Am I misinterpreting? Is the chronic pain management, infusion therapy, the other things that the bill, like on page 11, allows, is that strictly inside a hospital building under physician supervision, or are we going outside into the wild?
Well, I'll direct you back to page, and I'll have some other folks behind me that can answer more of that question as well. But if you look at page 1011, it will prohibit independent CRNA pain management and ketamine clinics. Independent CRNA pain management clinics. So that is on there, and there might be some other folks that behind me that can kind of expand on that for you if you to make sure you have a full understanding of the bill.
In this or any other statutes, does it define you're talking about it for prohibits independent, but how close does that consulting, the cooperating physician need to be in order for the CNRA to practice?
I do not have that in here. I think somebody behind me might have it. If not, I'll get, one way or another, we'll get back with you with a definite answer.
Thank you, Representative. Thank you, Chair.
Thank you. Any further questions? Seeing none. Thank you, Representative.
Thank you.
All right, we're going to alternate back and forth. So let's start with those in favor of. First one up, in favor of.
Hello. My name is Corey Koopmans. I'm a certified registered nurse anesthetist, or CRNA. I've been practicing anesthesia for the last 28 years, and have been practicing anesthesia in Missouri since the year 2004, when I was honorably discharged from the United States Navy as a CRNA. I'm here today speaking in support of House Bill 1561, as I have had a variety of anesthetic experiences and an array of anesthesia staffing models. By detailing some of my past experiences, I hope to shed light upon how different and misunderstood the practice of anesthesia by CRNAs can be. In 1996, upon the completion of my anesthesia training, I became a CRNA serving as both a hospital-based and U.S. Navy CRNA. I served both the Navy fleet hospitals as well as serving as a CRNA supporting the United States Marine Corps. In 2002, my Navy was tasked with providing support to the 3rd Marine Division being deployed to Iraq, an active combat zone, during Operation Iraqi Freedom 2. My unit provided medical support during this evolution as the 3rd Marines came ashore at Camp Coyote in Kuwait, traversed through Iraq, ultimately liberating the capital city of Baghdad. During my time spent as a Navy CRNA, we worked side by side, but there was never, and I repeat never, an instance of supervision of my anesthetic by a physician anesthesiologist, nor by a Navy surgeon, a Navy dentist, or a Navy podiatrist. There were no supervisors or supervisees in the United States Navy anesthesia ranks. Rather, there were only anesthesia providers, both physician anesthesiologists and CRNAs, tasked with providing anesthesia care for sick and injured sailors and Marines, both at home and abroad. During my time as a practicing CRNA in Missouri, I have worked in a variety of anesthesia settings. I have likewise worked for a prominent plastic surgeon as well as a vascular surgeon as an autonomous anesthesia provider, providing anesthesia in their office-based settings. Recently, I have worked as an autonomous CRNA provider in rural southeastern Missouri. I am on staff at St. Genevieve County Memorial Hospital, which is a critical access hospital in St. Genevieve, Missouri. Likewise, I am on staff at Farmington Surgery Center in Farmington, Missouri. In these rural settings, just as in the Navy, there is not a physician anesthesiologist supervising my practice. In these settings, the CRNA does what I call soup to nuts, meaning they take the patient through the preoperative interview as well as a physical examination. They select the most appropriate anesthetic type to be administered based upon the patient's health, their physical status, and the surgery to be performed. The CRNA then instructs the patient about the risks, the benefits, the indications, and the possible alternatives to the anesthetic. and has the patient consent for receiving such anesthetic. The CRNA accompanies the patient to the operating room, places on appropriate monitoring devices, and then provides a very safe and very cost-effective anesthetic for the patient. At the completion of the surgery, the rural CRNA concludes the anesthetic, takes the patient to the recovery area, and further oversees their awakening from anesthesia and discharge from the surgical theater.
Sir, I hate to do this to you, but your 3 minutes are up, so
Okay.
I know it goes fast,
Yeah,
doesn't it?
sure does. Thank you.
I apologize. Thank you. Representative Dahl. Proceed.
Hey there, thank you for being here.
Thank you, ma'am.
I just have, my questions relate more to the pain management side of this.
Yes, ma'am.
So are CRNAs currently doing pain management procedures?
As to the best of my knowledge, ma'am, there are 5 CRNAs who have gone through a accreditation. It's not a pain fellowship because physicians go through fellowships.
Right.
It's an accreditation. And those 5 individuals are practicing pain in the state of Missouri.
Okay. And are they doing that in collaboration with the physician?
Yes, ma'am.
And so I guess in those settings, does the physician have to be on site? What's that agreement look like?
That I do not know the answer to. I will get back to you on that one.
Okay. All right, thank you.
Thank you, ma'am.
Thank you. Representative Matheson.
I guess some of my questions are right on par with Representative Dahl's. I fully get the role of the CNRA within the hospital setting.
Yes, sir.
What potential new services are you as a CNRA going to be able to offer outside of a hospital setting should this bill pass?
I don't think ultimately, sir, that that's the goal of this bill. This
Okay.
bill is simply to bring what's happening on a day-to-day basis in rural Missouri in alignment with the legislature. Currently, we are providing anesthesia in the hospital and in surgery centers on a day-in, day-out basis.
So that we're limiting all of these services to in-surgery centers and in-hospital operating rooms.
Yes, sir.
All right, thank you.
Representative Keithley.
Thank you. To inquire.
Proceed.
So when the bill specifically talks about infusion therapy and chronic pain management, are those things that are done solely within the hospital context?
Oh, in collaboration with a physician, and I think it states
so
that
when
specifically.
we differentiate between the class, so you're talking about the part where we're talking about where we're changing the collaboration and supervision requirements. That's limited to the in-hospital setting, right?
Yes, sir.
Okay, that was my understanding of it. I think I didn't realize we were differentiating that question. And then you're specifically within the hospital setting. It sounded like
That is correct.
based on the questions and
That
stuff.
is correct.
And I have kind of like I guess the inverse question from Representative Matheson here, because I am kind of curious how this affects the hospital setting because I'm not sure I really understand how this really expands the scope. Like what surgery can happen if I eliminate. Like, for example, if I eliminate a supervision or collaboration requirement within just the hospital setting alone, the CRNA still needs some sort of physician, presumably, to do virtually all of these, if not literally all of these procedures. So I'm curious what I'm missing here. What surgery or what procedure that we've listed, surgery, obstetrical, therapeutic, diagnostic procedure, which of these can we do now without a physician present on site because we no longer have to collaborate or supervise with someone?
Well, I think, and I apologize for being a little verbose because I didn't get to the part where I wanted to tell you that we're currently being supervised by individuals like podiatrists, dentists, general surgeons, whose training in anesthesia is minimal to none. And I think that's the part of the situation, the equation that we're trying to rectify. And again, taking it back to my military background, we were the experts in the field, both physicians and CRNAs, providing care to the soldiers and the sailors. So what we're looking for is to remove the supervision aspect by those who are not currently experts in the field.
Okay, but when we're talking about like I understand that where the knowledge is based. So the CRNAs have the knowledge regarding the anesthesiology, and the physician who might be supervising them under the bill may not be trained in that, and that's not really what they're there to do.
Correct, sir.
And I get that train of thought. So I guess when we're dealing with this, we're not actually looking at, within the hospital context, we're not really expanding new surgeries then. We're not able to offer any new surgeries because I can't do it without a physician in the room anyway, because the physician has to do all the other things. When someone's on the operating table, There are a lot of professionals to do a lot of different things, and I get the CRNAs doing something different. But the CRNA has no reason to be in there doing anesthesia without someone doing the procedure. So I guess I that's what I'm wondering is when we're talking about the hospital realm here, are we really looking at an expansion of access to healthcare bill, or are we just talking about defining roles in the operating room?
Well, and I think I appreciate you bringing that up because I think that's going to be one of the opposition arguments that you hear is that this bill removes the physician-led aspect of the operating room. And I think that couldn't be any farther from the truth. There will still be a physician, like you said, a surgeon, a dentist, a podiatrist who has to order the procedure to be performed. And they will also order an anesthetic to be performed. So as CRNAs, we can't provide the anesthetic without that order being in place. So again, we're not looking to supplant the physician-led aspect of the OR.
Thank you.
Further questions? Representative Castile,
Thank you, sir.
proceed.
What does the term therapeutic refer to in the bill? Is that still going to require a physician?
Can I have a line item, sir?
Page 2, line 24.
The statement is a certified registered nurse anesthetist as defined in 335.016 may select, issue orders for, or administer a controlled substance, and it lists the schedules of the controls for and during the course of providing anesthesia to a patient for a surgical, obstetrical, therapeutic, or diagnostic procedure. I'm trying to think of, so a therapeutic procedure.
I think that might be where it has been mentioned that ketamine clinics will come into play if someone's feeling anxious or depressed or doesn't have any sleep issues.
Well, I would look at it as, I'm sorry to interrupt you, sir, first of all. The way I would look at it is somewhat piggybacking upon what you just said. In the preoperative theater, where a patient is anxious, we are tasked with giving them benzodiazepines, a medicine like Versed, like Valium in that same family. And currently, under the BNDD interpretation, the Bureau of Narcotics and Dangerous Drugs interpretation, we should have an order on file or a protocol in place for administering that medication.
Thank you. And then the other thing is are the CRNAs equipped to handle adverse reactions to administered drugs?
I think that's well within our scope of practice and well within our scope of training. Yes, sir.
Because as it was said to me, the anesthesiologist will review or monitor the prescription or administration of these drugs to several different surgical rooms at a time. But before doing so, they thoroughly review the charts. And so I guess back to the ketamine clinic scenario is that if they get a high volume of patients wanting to be administered some Schedule II drug and they don't have the time to review the charts properly, is there a worst case scenario where some drugs could have an adverse reaction to, or a patient could have an adverse reaction to drugs and not have help nearby in order to be treated or saved?
Well, I think in my case, sir, when we're talking about rural CRNAs, we're typically not working in a ketamine clinic. Those ketamine clinics, pain practices are going to be in a more urban hospital setting where you have a physician anesthesiologist typically present. So again, they may have the opportunity to further delve deeply into that chart and know the patient's history. But in our rural settings, we provide safe, cost-effective anesthetics to our patients during the operative theater.
Thank you very much.
Thank you. Further questions? Representative Dahl.
Just really quickly.
Yes, ma'am.
So is it true that currently, the way that medicine is practiced, which I understand CRNAs are running the pre-op and the post-op show, that technically that is not legal because there should be a physician in the room at all times?
No, ma'am. I think we are working with the physician who is acting as our supervisor, be it the surgeon, the dentist, the podiatrist, the obstetrician. So long as that person is readily available, we are within our scope of practice.
Okay, thank you.
Thank you. Seeing no further questions, thank you for your testimony, sir. Next up in opposition.
Committee, thanks for listening. Some handouts to review. My goal is to do this in 2 minutes, but I'm not going to try to do it at auctioneer speed. Matt Satterley, I'm an anesthesiologist in St. Louis, Missouri at Mercy Hospital with Western Anesthesiology Associates, and I'm currently the president of the Missouri Society of Anesthesiologists. It was kind of nice to hear the ER discussion beforehand because it really frames a lot of this. I think this is a bill looking for a problem. Every patient today in the state of Missouri that needs an anesthetic can get it. There are nurse anesthetists, as we've heard delineated, that are covering the pre-op, and that's within their scope, and that's within Missouri statute, and they're acting appropriately to do that. They do currently have a physician, surgeon, podiatrist, dentist supervising that care. But again, every patient that needs an anesthetic today can have it. So this does not expand scope. This does not expand access. This does not change the shortage. And I will note that I looked it up. Anesthesiology only had 3 unfilled vacancies in the last match. But again, they've addressed the ER issue, but it's still an in-demand specialty. I've been thinking of an analogy to try to frame this all day, and one was provided to me. If you have a sniper, no doubt they're probably better trained at taking that shot from a mile away than the commander that's going to say, pull the trigger. And I think a nurse anesthetist, and I'm not picking on the urologist from earlier, probably knows a little bit more about anesthesia than that urologist. And I say that tongue-in-cheek. Certainly they do. But that urologist went to medical school. That dentist went through the equivalent of a medical school training. That podiatrist went to school and knows more about global health, knows more about the patient, about the system, and knows more about the battlefield like that commander does than the sniper taking that shot. I think you want the sniper to take the shot. You probably want the nurse to put in the CRNA to put in the breathing tube. But I think that, you need physician-led care, and I think that's the highest standard of care. And today in Missouri, that is the status quo. This doesn't change that. This doesn't open that up. I think it changes that level of care. I think the whole issue of pain clinics and ketamine clinics is an entirely different issue. Right now, my understanding, and someone in the audience can come behind me and correct me, the CRNA can't independently provide that care without medical supervision or direction of a physician. This bill will open up collaborative practice, which CRNAs currently aren't able to do in Missouri under our statute, to where they can do ketamine clinics. They can go to rural Missouri, open up a TP and infusion clinic, and there was recently a patient in Texas that died from that. And that's beyond my scope. That's not what I want or really know how to do. I am board certified in chronic pain management. I'm not practicing it currently, but I do believe, much like a neurologist, where you're going to bypass Ironton to take that stroking patient to where a neurologist or a neurointerventionalist, an interventional radiologist, a physician, can go in and retrieve that clot and get it out with help of great nurse practitioners and ICU nurses that are going to keep that patient going. You're taking them to that specialist, and I think in chronic pain management, that specialist should be a physician. I'm getting close. I'll stop.
I'm sorry to do this to you guys, but again, I want everybody to be able to speak. So any questions for this witness? Seeing none, thank you very much for your testimony. Next up in favor of.
Shooting for 234. All right. My name is Zach Smith. I'm here to speak on behalf of the CRNA students here in Missouri. I graduated as an RN from Mercy College in Springfield, and I worked 7 years exclusively in the intensive care unit. I've had the opportunity to work in hospitals in Missouri from level 1 trauma centers all the way down to small community hospitals. I was admitted to Missouri State University's CRNA program, where I'm currently a student nurse anesthetist, and I will graduate in May of next year, hopefully. As a former ICU nurse, I was trained to be extremely vigilant in the care of my patients, and this carries over to my current education. CRNA students actually utilize the same textbooks and the techniques that our anesthesiologist counterparts use. When literal seconds matter, we're being trained on what to do, when to do it, and how to send all of our patients home safely to their loved ones. Upon graduation, I'll have approximately 2,400 hours of training on top of my measly 13,000 hands-on clinical hours as an ICU nurse. Many Missouri CRNA students are kind of facing a major dilemma. We all struggle with where we're going to work after graduation and where to raise our families. We have 43 other states to choose from that do not require burdensome supervision for the surgeon, podiatrist, dentist, or restrictions on our future licenses. Missouri only graduates about 80 CRNAs every year. Of those 80, approximately 32 choose to leave the state. I actually conducted a survey of CRNA students, and the number one reason that they're leaving is they want to be able to practice at the full scope of their license. This leaves Missouri with 48 new CRNAs to fill the 202 positions that are currently open. Instead of giving us reasons to leave, just give us the one major reason to stay. I live within easy driving distance of Arkansas, Oklahoma, and Kansas, which are 3 of the 43 states that have updated laws to reflect how anesthesia care is actually provided in an operating room. I do not want to serve the people of those states, and I certainly don't want to use my skills outside of Missouri. My family has deep ties to this state. I'm just a good old boy that was born and raised in the Ozark Mountains. I love the idea of providing health care to those in desperate need in rural areas of Missouri, but unless this law is changed after graduation, I will move to a state that openly embraces my expertise and training. Politicians always talk about wanting to make Missouri a great place to live, work, and raise a family. You all now have that opportunity for my family and other students like me. I ask that you please support House Bill 1561 so that myself and my fellow students have the opportunity to stay in Missouri and serve the communities that we love. Thanks.
Very nice. Let's see. Representative Dinkins,
To inquire.
proceed.
Okay, so you feel like you're fully qualified and have the training to fulfill this role?
I'm still in school, but upon graduation,
upon
I do
graduation.
feel that I will have the training necessary to keep someone safe and alive in the OR.
Okay, I mean, you mentioned without supervision and with full scope, so you're currently still in college. So why would anyone want to be an anesthesiologist if they could do less time and still perform the same
I
role?
think that's up to each individual. I feel like why do people go to PA school when they could be physicians, or why don't people just go to PA
I mean,
school?
why are we even having anesthesiologists? Why would we even need them?
I don't know. I'm not the one to answer that question. I don't know why anybody would choose to be that. Bigger hospitals are going to choose to have them. Mercy in St. Louis and Truman in Kansas City, they're going to choose to have anesthesiologists. This bill, from my understanding, does not override a facility's ability to hire anesthesiologists. If they want to have them, they're more than welcome to. I have no desire to work in a large city. I want to work in a small rural hospital where I can replace knee or be there while a knee is being replaced, or grandma's getting her vision back, or a kid's getting their ACL repaired after playing softball. I don't care to do heart transplants and craniotomies. Like, I will have the training, but I have no desire to do that. I want to go to the small areas.
Okay, thank you.
Representative Dahl, proceed.
Hi there. Thank you for being here. So can you just walk me through, in the other 3 states that you're surrounded, Arkansas, Kansas, and Oklahoma, what could you do there that you're not currently able to do in Missouri?
Per my understanding, the physician does not have to sign off on the chart of what I have done. I like to relate it to, imagine you're a plumber and you're dealing with a nasty poopy leak, excuse my language, and in the middle of doing so, the electrician comes up and is like, hey, bud, what wire do you want me to run? It's the same with a dude that's replacing a knee or doing a gallbladder. They're focused on their surgery, and I'm trying to keep that patient alive. Right now, I'd have to be like, hey, so their blood pressure's tanking. What do you want me to do? Instead of actually just handling the situation as I've been trained. Does that answer your question?
It does.
Okay.
Thank you.
Other questions? Representative Keithley,
Thank you, to inquire.
proceed.
So I guess I have a couple different areas to touch on with you, but we start with you brought up the rural areas, and it was kind of similar to what I had asked the last CRNA who came up here. I mean, right now, if you're in a rural hospital setting, you don't need to have an anesthesiologist in the room, right?
Correct.
Right now, you could.
I believe that is per hospital policy.
CRNA. Right now, I mean, you do have to have a physician in the room to do the collaboration and supervision, whatever.
There would be no
the
point in being in
requirement
there
is.
without the supervision or a physician in the room.
And if we pass this bill, we still have to have that physician who's in the room who they may not have to sign off on what you're prescribing. I won't say prescribing because that's part of my next question, by the way. But they may not have to sign off on what you're doing or decisions being made, but they still have to be in the room or be present because they're doing all the other functions.
Correct.
So I guess what I'm left with is just wondering is how what can CRNAs really do? I understand that the signing off, but is this first half of the bill that just deals with the hospital setting? Are we just talking about another signature on a sign off sheet? Can we get rid of half this bill? Is all we're truly addressing on that first part within the hospital practicing just who signs off on what's being done?
I'm a student. You'd have to ask people that are way more involved in
Yeah,
that.
and I asked the last CRNA, and
Yeah.
he said, yeah, we're not really changing. I mean, I don't want to put words in the mouth, but it sounded like the answer was, yeah, we're not really changing that relationship. We're just
No,
changing the
to my understanding,
administrative
we're not changing it, but
procedure of that.
I've had the great opportunity to work with podiatrists, and as the gentleman behind me said, they do have medical training, but while he's down there doing his thing, I'm worried about keeping my patient alive, and I'm not going to ask him, hey, they stopped breathing, do you want to come up here and take care of the airway for me?
So the next, so we're not, it's not about more procedures, it's about, well, I guess I know we're short on time, so I'll get to the second part of the question. As part of, since you're a student right now, and this specifically to this part, are you currently, through your process, and as we're educating CRNAs today, are we teaching them on all medications? Are we teaching them even on the medications that they currently are not allowed to be prescribing?
Yes, because you need to know issues that may arise with certain medications that a patient is taking. So we do cover, obviously, the basics of this is what I'm commonly going to use, but there's several medications that interact negatively with anesthetics, and so we want to be aware of that and potentially change the anesthetic plan.
So with that, when you're talking about medications that, well, these we can prescribe, these we can't, there's different roles with what CRNAs are allowed to do with medications, and depending on the medication, how far you can go, what you can do. There's something I was confused about in the bill is it offers wide. It seems. It very literally stops short of allowing CRNAs to prescribe certain things, but it certainly says administer, and I get the difference between prescribing the medication and administering the medication. I'm not so sure I'm clear on the differences between selecting the medication and issuing orders regarding the medication and prescribing the medication. What is the legal distinction between selecting and issuing orders and administering? If I can do all those three things, what is left in prescribing that I can't do in those three? And I don't know if that's something that's covered in the difference in medications. I'd raise that question to anyone else who wants to
I would
come
ask
up and
that question
address
to
that as well. So
someone that's super credentialed.
okay, and just in general, I'll just throw this out as part of that question. It's just I'm having trouble understanding. It seems like we're saying you can't prescribe, but then we're giving the authority to do everything else around prescribing. So
Per
if
my
someone could
understanding,
talk to
that's only in the anesthetic setting. So pre-op, intra-op, and post-op. I have no desire to prescribe someone before they're even coming to the hospital take this medication, or once they leave the hospital take this medication. That should be up to their provider who's doing the said surgery.
Okay, I appreciate it. Thank you.
Further questions? Representative Lewis. Proceed.
Good afternoon. Thank you for being here. And congratulations on your education and your schooling. So I went and during the interim talked to some CRNA students about policy in this bill in particular, and it was a different CRNA school here in the state of Missouri. However, many of the students I spoke with said that when they graduate, they plan on going out of state. So that we have a workforce shortage, which you heard in the other hearing. We hear that often, and so it's a little frightening to hear. You're thinking that you pulled your peers, and I had the same experience. So I ended up, after talking to the CRNA students, ended up sponsoring the similar bill. So obviously, I'm in support of it, and I've learned a lot, of the practice. So I think, and this came up last year in a different committee, and I think there was some confusion with the different roles. And the surgeons want to do their surgery. You want to protect the airway, keep us alive. I recently had surgery myself, and about 3 weeks before the phone call, someone from the anesthesia team called me. I don't know if it was a CRNA, an anesthesiologist, or whoever. And they asked me what medicines I'm taking. They said, don't take your multivitamin 2 weeks before surgery because of bleeding. I said, okay. And then a couple weeks prior to my surgery, I went and saw the surgeon, and I said, well, I met with the anesthesiologist over the phone, or the anesthesia team, and they said, don't take this, and I can drink coffee, and I can do all this or whatever. And I was confirming what anesthesia said with the surgeon, and the surgeon said, it's whatever they say. That's their job. I'm just worried about the surgery, so follow those orders. And then when I had surgery, I got, I think, one of those little doses of something where I wasn't so stressed anymore. And that was with this CRNA, and that was before surgery. I think the surgeon was probably scrubbing up or anything like that. So anyway, I think, and what we heard last year, just, I mean, it's just so fresh in my head because I just had surgery a couple weeks ago or a month ago, is that we heard testimony, and I don't know if we will today, that the surgeons, the podiatrists, the dentists, don't want to be responsible for what you're doing. There's a shield there. You're worried about the airway, and they just want to be responsible for their practice and what they're doing. Is that accurate?
Yes and no. I mean, some would prefer an anesthesiologist, and that's perfectly fine. That's understandable.
Yep.
But in my training that I've worked with, they've all been very comfortable with CRNAs. I know that last year during a similar hearing, we actually had several surgeons that came up and testified in favor.
And that's what I was getting at. I'm sorry
Yeah.
if I wasn't clear. That's
No,
what I was getting
yeah.
at. The surgeons don't want to be responsible
Right.
for
And
signing
that's
off.
every provider's decision to make themselves. It's not for me to be like, oh.
Right.
You know.
And this, as the bill sponsor said, I just want to point out, as the bill sponsor said, that he calls this the CRNA Freedom Bill on page 10, line 24 through 27, it says that like hospitals or healthcare systems can adopt additional provisions around anesthesia physician care if they want.
Yeah.
So, all right. Well, good luck with school, and thank you for being here.
Thank you. Any further questions? Seeing none, thank you for your testimony. Next up in opposition.
Thought we were going to have a collision.
Representative, did you need to be up there to opposition?
We've changed his mind already.
Thank you, Mr. Chairman, members of the committee. Excuse me. I'm Dr. Randy Mullins. I'm a vascular surgeon at Cox Health in Springfield. I have the privilege of being the chair of surgery and the director of surgical services for the healthcare system. And I know that there are some surgeons here who are testifying in support of this legislation. I think it's important for the committee to understand where the bulk of our profession stands on this issue. We've distributed a copy of a letter from the American College of Surgeons in strong opposition to this bill, and I'm here testifying on behalf of the MSMA. I'm here because House Bill 1561 concerns me deeply. It proposes letting CRNAs have full control over an anesthesia care plan and the autonomy to, quote, select, issue order for, administer controlled substances for surgical, obstetrical, therapeutic, or diagnostic procedures, end quote, without physician supervision and without prescriptive authority from the BNDD, essentially Missouri's DEA. This might sound like a step towards efficiency, but it overlooks the crucial safety net that physician involvement provides. In surgeries, knowing a patient is safely anesthetized is our top priority. It's not just about the procedure, it's about ensuring a patient's safety throughout the entire perioperative process. In most hospitals, we're staffed with physician anesthesiologists who lead an anesthesia care team with CRNAs, anesthesiologists, helping plan and execute the anesthesia care plan for each procedure. We do have 2 rural hospitals, critical access hospitals, where we don't have an anesthesiologist, and the CRNA staffs those ORs. We try not to do complex surgeries in those hospitals, and they're comparatively low volume. A critical access hospital does less than 800 cases per year. We try, in no small part, that's because of the resources available at that institution. Some things need to be done where they're done frequently and done well. It's why we work with protocols that define what anesthetics our CRNAs can use, how much. This isn't about restricting capabilities. It's about ensuring a structured, medically approved plan that they can operate within without needing to interrupt an operation. If a situation requires going beyond these protocols, A verbal confirmation from a physician is all it takes to adjust the plan. That's a system that's in place now and seems to work well. This system seems to balance efficiency with safety. The argument for this bill may stem from a desire for autonomy and efficiency, especially in settings lacking immediate access to a physician anesthesiologist. But let's be clear, surgery isn't a routine task. It's unpredictable. I'm not wearing a tie today in no small part because we don't wear ties in hospitals anymore. They spread infections. No comment on anybody wearing a tie. But I came straight from work where I did an exposure for our neurosurgeons on the spine in a woman that weighs 104 pounds. And the specific area that we were going to, I made the tragic error. I thought this one's going to be a chip shot, and it wasn't. It was hard. There are major vascular structures in the way, and it took a fair bit of doing to move them safely out of the way. There is no such thing as a routine operation.
Doctor,
Sir.
I'm sorry, but 3 minutes are up. But I will commend you on your not wearing a tie. Any questions for this witness? Representative Keithley.
Thank you. To inquire.
Proceed.
I'd like your take on it from the physician side and the surgeon side. It's a similar question I just asked, where the bounds are, because I'm trying to understand the prescription process this bill lies forth. Where we'd be authorizing CRNAs to select medications, to issue orders on the new medications and to administer, but then it says, but they can't prescribe. And I just want to know, where are those? What are these actual distinctions that that medical professionals are taught, that if you can issue orders but you can't prescribe? What is the difference in those processes? I'm trying to figure out what we're getting at by using these specific terms.
You're making me feel better because I get the same question. To say that creates a lack of clarity is an understatement.
Okay.
And
it's if I'm someone overseeing this process, I think the law painstakingly dictates who is authorized. I mean, this a lot of times is the major distinction between, how we differentiate between different professionals in the medical community, is the level, literally the schedule at which your prescription level runs out. And it's to me, it's like we should be very clear about who is responsible and where that responsibility begins and ends around certain types of medications. If you have the ability to administer something, I want to be able to track and know where the prescription came from, not just where, who ordered it and who showed the order. So that's, I'm going to keep asking this question until someone can provide me an answer what these specific terms mean.
I couldn't agree more with that. And I would just add that we are still trying to survive an opioid epidemic, which started in no small part because of a lack of accountability to begin with. And that was with supervision. That was with licensing requirements.
Thank you. I appreciate it.
Representative and Vice Chair Parker.
Thank you. To inquire.
Proceed.
Thank you, sir. I had a quick question about, you indicated earlier that there are protocols in place that set up the medically approved standards. This is what happens and what CNAs can do. Is that correct?
Yes, ma'am.
And if it is beyond a protocol, you said that a CRNA can get verbally authorization from the physician. Is that right?
Well, if we're doing an operation together and something slides off the rails, or something out of the protocol or ordinary occurs, then yes, we would expect the CRNA to direct our attention to the issue, and then we would discuss it.
Which physician? The one that actually ordered the procedure or the anesthesiologist?
So there's two answers to that. It depends on which hospital or healthcare system you're operating in. If you're operating at Cox South, our flagship hospital, Level 1 Trauma Center, Level 1 Stroke, Level 1 STEMI Center, there is an anesthesia physician either in the room doing the case or immediately available. At our two critical access hospitals, the surgeon is the supervising physician, and the routine is for the CRNA to discuss the issue with the surgeon immediately in real time.
So you believe that this bill would completely eliminate that verbal authorization? They see something, they could just, CRNA would just do it right then?
Well, it's hard for me to predict what other people might or might not do in the
Right,
future.
I understand.
But it sure takes the guardrails away.
Okay.
And the person that testified ahead of me even went so far as to say, if something goes sideways, I'm going to focus on keeping the patient alive and not bother to visit with the surgeon. I find that probably suboptimal. Healthcare is a team sport. There is no way any of us can do this alone. No way. It's not possible. And when we do anything that takes away from that team being successful, we're setting ourselves up for catastrophic failure.
Thank you, sir.
Other questions? Seeing none, thank you very much, sir, for your testimony. Up next, in favor of. Any more in favor of? Next up, in opposition to. Well, favor?
Good afternoon, Chair Coleman and members of the committee. My name is Jason Wilson, and I am the administrator for the Mercy Hospital in Lebanon, Missouri. Me as a leader and a co-worker for the Mercy Ministry are in support of this House Bill 1561. At Mercy Lebanon, we believe great care should never be far from home. This is why we provide a 58-bed acute care general medical surgical facility that is fully accredited by the Joint Commission. We delivered 190 babies and performed 3,900 surgeries last year. This only gets to happen because of the anesthesia services our CRNAs at Mercy Lebanon provide to their neighbors. I'm requesting your support with this piece of legislation because it is desperately needed for our Mercy Lebanon Hospital as well as other healthcare facilities across the state. At my hospital, we do not have an anesthesiologist. We only use CRNAs. Without CRNAs, surgeries would not happen in my community, and patients would be forced to travel hundreds of miles to get the life-saving health care they need. One of the biggest complaints I hear from my surgeons is they are fed up with having to sign off on anesthesia delivery from our CRNAs. They continue to say, the CRNA is the expert. I don't know anything about anesthesia. Why am I signing off on something I have not trained in? The point is revisited during our recruitment efforts and is seen as a burden by our candidates, which are negatively impacted by our overall recruitment efforts because of this point. We have and will continue to have a major anesthesia provider shortage in Missouri with our existing law. It makes it much harder to recruit and keep the CRNAs we have. I continue to have CRNAs tell me they do not want to work in Missouri because they can choose 43 other states, including all the border states around Missouri where this is in effect. CRNAs should stop being forced to choose between the safety of the patient or following some ridiculous technicality that could jeopardize their license. This bill will guarantee with certainty to fix the issue once and for all. I would never sit here and tell you what's good for my hospital is good for all the hospitals across the state. This bill will allow the large hospitals in Kansas City and St. Louis to keep doing it the way they're doing it. Their model works, but it gives us the opportunity to do what we need to do. In closing, the Lebanon community, as well as numerous other areas of the state, need your help. This bill makes sense by allowing a safe and realistic anesthesia option for all healthcare needs, which equals a win-win for the entire state. Thank you.
Awesome. Thank you. Questions? Representative Matisse.
Good afternoon, gentlemen. Question regarding the current surgeons needing to sign off on the anesthesia plan. How much additional time does that cause that surgeon for each surgery? How much,
It's not a huge impact of time. It's not. It's just the idea of them being in there and have to follow up with them on, they're counting on the CRNA to know how it's done and it's almost
Sure.
an after the fact concept.
Okay, so do surgeons generally have knowledge of anesthesia? Is that part of their medical school training to begin with? Is this really a new thing for them?
I can tell you, like I mentioned, the ones that I talk with, and we have a fairly steady staff of around 8 or 10 that come there and work.
Mm-hmm.
The common thing with them is no, they do not have that training. I can't speak for that, but that's not the way they relay it to me.
Yeah, I can completely envision, the role of the CNRA in the hospital and how this can simplify it. Are you aware of any concerns of any states that have expanded the scope of CNRA practice for them to utilize that scope outside of a hospital building?
I'm not aware of it, no.
Okay, thank you.
Yep.
Yes.
I actually have a
Representative
different
Keith.
question.
Yes, go ahead. Here's the thing. I apologize. How many do we have left to testify? Oh, wow. Okay. Go ahead. We will be coming back.
So I can't remember if I heard you right. It sounds like your hospital is predominantly, if not all, CRNAs.
It is all CRNAs.
It's all
We
CRNAs.
do not have an
And
anesthesiologist.
that's under the current law. You're not violating the law in
No.
any way having all CRNAs. So you're not required to have anesthesiologists right now. No. The law, obviously, you'd keep your CRNAs. I guess I'm trying to figure out what procedure in the hospital setting, because everyone who's spoken in support is coming at this from the hospital setting and that part of it. I'm trying to figure out how we're improving that process, because what I've heard so far is, well, we don't have to have the doctor sign off on it. And you've just said that, you said in that last response that doesn't take that long to do. And I can't imagine it would. The doctor's standing right next to you a lot of times in the same room or in their office. I get they're not constantly in the room while the procedure's going on for every single minute of every single hour that's going on, but they're on site. They have to be on site there because the procedure is related to the anesthesia being admitted. So of course it wouldn't take that long to sign. A lot of times you're just going to the person right next to you to do it. So I'm trying beyond the signature. What is the other procedure that we're improving?
That's really the culmination of it, obviously, with recruiting efforts. But as far as the procedure itself, it's that communication mechanism between that surgeon and that CRNA, and it goes back to the surgeons questioning my surgeons. Why are we having them go to us when that's really what they were trained in? And they're asking our expertise on something that we didn't get the training in. And like I said, I'm just speaking for my staff that talk with me.
And you think it's actively hurting your hospital's ability to recruit new CRNAs because they have to go through this process?
I can tell you it does. We've had more than I can't even tell you a number of them, more than a few that have mentioned that they are. And keep in mind, we have a lot of them that come from out of state. And that's the one thing that's always when they come, they're like, I'm not a fan of the not being able to practice my license to its fullest extent in Missouri. And like I said, every state around us, they can.
Okay. Thank you.
Yes, Representative Dinkins.
To inquire.
Proceed.
So I've heard a lot of people mention about teamwork in the surgery center and things like that. So do you feel like you all practice that in your facility?
Yes.
I'm just kind of surprised to hear you say that when you said your surgeons are saying they're sick and tired of having to sign off, and, it seems like they would want that communication and that collaboration. Sometimes when I say something to my fellow colleague, me saying it realizes what I needed to hear from myself, whether I need to go fix something or I should have done something differently, just that communication. And you mentioned communication mechanism, and I feel like communication is a good thing and not a negative aspect of it. So I was kind of surprised to hear you say that, and also that the people don't want to come to work because they don't want oversight.
It's almost, I feel it's the opposite of what you said. I think that it's because of the level of respect that our surgeons have with our CRNA staff that's where it's coming from, because they're held in high regard. We have a great team of CRNAs and surgeons, and when I say by opposite, them surgeons have a lot of respect for what the CRNAs are doing, and that's where that comes from, because they feel, why are we having to make a decision on something where they know good and well and they've proven it to us time and time again, and they have that training. So that's where it's coming from. It's not a negative of, there's not a communication breakdown. It's more of a respect for what the CRNAs are doing and them feeling they
and
shouldn't
respect
have that
is an
oversight.
earned thing, like you said, they've proven time and time again, but we heard from the gentleman before that he is just now finishing up his schooling. So we're always going to have that cycle of new people in that, need a little supervision, a little guidance, a little extra oversight. So I don't feel like it's negatively impacting, what you're able to do. Thank you.
Representative Dahl. Proceed.
So thank you for being here. I appreciate your testimony. And I'm guessing when you say your physicians don't want to sign off on it, it's not as much that they don't want to sign off on it, but you're asking them to sign something that they know nothing about.
And that is coming from them. Keep
Understood.
in mind, I don't want to put any of it in my mouth. That's coming from their opinion on it. And it isn't really, I don't want to say they don't want to sign it. They just feel that the system is broke in their, I guess I don't want to put them words in their mouth, but that's what I get from them. They feel it's broke because they're having to sign off on something that they feel the CRNAs have the proper training on that they don't.
Right, I understand. And as someone that comes from healthcare, I think it's uncomfortable to be asked to sign off on something that is not within your expertise. So I get that. I don't think it's merely just the act of signing, it's the principle behind it. Thank you.
Yep.
Representative Stennett,
To inquire.
proceed.
So on page 2 of this bill, it says that a CRNA shall not be required to enter into a collaborative practice agreement to provide anesthesia services under the supervision of these physicians, dentists, podiatrists, or to obtain a certificate of controlled substance prescriptive authority in order to exercise the authority in this subsection. So who's going to be responsible for that prescription? And because earlier it says select, issue orders for, and to the point made prior, I think that's very confusing terminology and not defined anywhere else. So whose DEA number or whose prescriptive authority is this going to live under if they're not in a collaborative agreement, if they're not having to obtain a certificate to provide this authority?
I can't speak for how it would. I can just say that kind of like we're talking in our hospital, in the OR setting, that's part of that. Anywhere out of that, they are not prescribing anything. It's just in that OR setting to where when we're having surgeries, that's the role. Anything past that, I don't have an answer at this point on that.
Is it your organization's preference that this bill be targeted more toward a hospital setting and not be looking at things happening outside of a hospital?
I don't want to speak officially on that, but I believe that's the conversations I've had, that we are involved in the hospital setting.
Okay. I mean, just to make a comment, I don't think this is something that necessarily you'll have an answer to, but feel free to make a comment. I think the bill in some ways is, again, somewhat confusing because it has on page 2, patient for a surgical, obstetrical, therapeutic, or diagnostic procedure, and it talks about not requiring collaborative practice. It goes on later to say something very similar, not requiring collaborative practice. And then on the last page says, but you have to have collaborative practice if you're doing this infusion therapy or pain management. But there's no definition of the therapeutic. So could they do something outside? I just think there needs to be some clarifying language. These are very sensitive medications. I mean, I pulled up the whole list of all the scheduled substances, and the rationale for them being scheduled is that they're dangerous. And so I just think as a committee, we need to be really cautious and careful about how we consider these things and make sure that we're not opening doors that we're not meaning to open.
I totally agree. And I hope and expect that there might be somebody that's still wanting to speak that can answer that better than me.
Sure. Thank you.
Yep.
Further questions? Seeing none, we are taking this moment to recess. We will return to this room immediately following the adjournment of session. So we are now in recess. We are going to reconvene our committee meeting here. And where we left off was with one that was in favor of. So is there anybody here that is in opposition? And once again, I apologize, but we are going to keep it to 3 minutes, just so you know, to be fair to everybody before you.
Thank you, Mr. Chairman.
Thank you.
Hi. I'm Dr. Ravi Johar. I'm an OBGYN, and I apologize. I'm here testifying on behalf of ACOG. And I apologize for not having a lot of written testimony prepared. I actually came up here for some other purpose at the House today and saw this on the agenda and felt compelled to come talk to you a little bit about it. As an OB, I'm familiar with ketamine. We used to use it for deliveries in obstetrics and gynecology. We no longer do that. In fact, I've only seen two ketamine deliveries in my life, and one of them was the attending did prove to us why we didn't want to use it. Ketamine caused problems for moms, babies, nurses, and the OBs. It was just simply not a safe drug, even in a hospital setting. It's concerning. And when I read the parts of this bill that talked about the therapeutic use for obstetrics in an outpatient setting, not even in a hospital setting, it really gave me a lot of fears and worries. Ketamine, if you need proof that it's not a dangerous drug, just look at Matthew Perry. There's a number of things that can happen with ketamine or with any other medication, and that's in a controlled setting. And this bill, I got very confused sitting in the audience, and if I was confused, I imagine you guys may be also. Everything I heard said that this wouldn't change anything in the hospitals. So then what it leaves is what happens in an outpatient setting, in the storefront. And that's where my concern is. Using ketamine or any other dangerous drugs, that's how it's defined, in an outpatient setting is inherently risky and dangerous. And being able to set something up without any kind of oversight, any kind of restrictions, any kind of use at all strikes me as being something that's inherently dangerous for our patients and concerns me greatly. And I haven't heard anything to show me why it's not doing that. So the therapeutic use and outside the hospital is just extremely concerning to me. The two ketamine deliveries I saw, one was a lady that just was out of control to the point where we actually had to talk about putting her in restraints. She was kicking out at the nurses. It was dangerous for the nurses. It was dangerous for everybody to have that delivery. And that was the one the attending wanted to show us. The other one was one that went the other extreme. That's why ketamine, for example, is such a dangerous drug. She was basically completely almost comatose delivering her. It was delivering someone that just had no sensation at all. When she woke up, her only question was, when am I going to be going into labor? I want to have my baby. And we had to show her the baby on the other side of the room. She missed out on everything. And then it took her another day to realize that this truly was her baby. We hadn't pulled any fast one or anything else. The amnestic effects, the different effects, and I'm sure the anesthesiologists who know this medication can talk about how other effects from it. It's just a very, very dangerous drug, and it just scares me.
Very good. Any questions for this witness? Seeing none, thank you very much, Doc, for your time and your testimony. Next up will be anybody else here in favor of. No.
Sorry.
There you go.
Good afternoon. On behalf of Golden Valley Memorial Hospital out of Clinton, Missouri, we want to go on record in support of the bill. We are a rural hospital. We also utilize CRNAs in 85% of our surgeries, and we also lose CRNAs to other states, so we would appreciate the support from the committee. Thank you.
Mr. Tuttle, would you please fill out a witness form for us, please?
I did that online, but I can fill one out also. You don't have it?
No, we're not seeing
I'll fill it out.
Thank you. Are there any questions for this witness? Seeing none, thank you for your testimony. Next up, in opposition.
All right. Mr. Chairman, distinguished committee members who are here, I'm Dr. Timothy Swearingen. I'm the president of Ozark Anesthesia Associates out of Springfield, Missouri. We're a group of nearly 30 anesthesiologists and 45 mid-level providers, including both CRNAs and AAs, and I'm here to testify on behalf of the Missouri State Medical Association in opposition to this bill. I would like to begin by saying that I'm not anti-CRNA in any way. My wife is an ICU nurse, and one of my closest friends is a CRNA. He and I worked together flawlessly for nearly 20 years. CRNAs are an integral part of our healthcare team. Having said that, with my relationship with these two individuals, I'm keenly aware of the difference between nursing and medical education. I work with CRNAs every day in my practice, and some of my colleagues who you will hear from shortly, are CRNAs who chose to go back to medical school, do an anesthesiology residency and a fellowship. And there's a quote attributed to Albert Einstein that says, "The more I learn, the more I realize how much I don't know." Now, I don't know whether this is, he actually said this or this is one of the many quotes inappropriately attributed to Einstein. Either way, it's a profound and truthful statement. Many CRNAs believe that they know all that they need to know to practice independently because they have not delved as deeply into the subject matter as is required in medical school and anesthesiology residency and fellowship. On a daily basis, I feel these knowledge gaps for the mid-level providers that I work with. To allow them to practice without physician oversight would surely put patient safety at risk. Now, many people think of anesthesia as putting patients to sleep for surgery, and therefore they believe CRNAs are adequately trained to do that. And that is part of what we do, but the reality is that's only a part of it. We're perioperative physician consultants. We must know when it is or is not safe to put a patient to sleep, do a procedure, how to respond to any complications or emergencies that may arise, and this is where the knowledge gaps are the greatest. Now, let's be honest. We've beat this to death here, and one thing has surely come out of this. We know this isn't going to change anything. Surgeries are already happening. CRNAs are allowed to practice. They just don't want to have to get a signature from a physician. And once again, with the protocols that the BNDD has established, they don't even have to get that most of the time. They only have to do that if they go outside the guardrails. So my perspective on this is that the first part of this bill is smoke and mirrors. And what this is really all about is getting to the last half of the bill, which is allowing CRNAs to open ketamine infusion clinics and pain clinics and to practice independently without physician oversight and without a BNDD number, so therefore no governmental accountability either.
And I'm sorry, Doctor.
That's it.
3 minutes goes fast, doesn't it?
Nope, that was the end.
Is there any questions for this witness? Yes, Representative Roberts.
Thanks, Mr. Chair, to inquire.
Yes, please
I've
proceed.
been dying to have you sit down ever since Representative Dinkins asked the question, why would anybody want to be an anesthesiologist? And I think I heard the witness apparently profess bewilderment about why anybody would want to be an anesthesiologist. Could you comment on that for us?
Yeah, so, well, I think what they're getting at is if you can study for 2 years and do the same thing as if you can study for 12 years, why wouldn't you take the 2-year route? And I think that's the issue here, right? Is do we want only 2-year route providers out there, or do you not want anyone with the 12 years of education and residency and fellowship who are overseeing the actions of these 2-year shortcuts? But the reality is, I thought I wanted to be a surgeon until I worked during my undergrad for an anesthesia group as an anesthesia tech. And I saw what the anesthesiologist did on a day-to-day basis. And going back to whether it's an Einstein quote or not, scratching the surface, man, when you dive into their education, their understanding, and all that they do, and one of the running jokes in my business is occasionally have to make it look harder, else everybody thinks they can do it. And that's the reality, is we make so many things look so easy that it does seem that way. But there's a lot that goes into making that look that easy.
I appreciate it. Thank you, Mr. Chair.
Further questions? Yes, Representative Deakins.
To inquire.
Proceed.
Okay, how much time do you think you have to spend? You mentioned 12 years going to school. How much of that time is actually in the hospital practicing, or I don't know if it's called a residency or what it's actually called with you all?
So, yes. So the 12 years is 4 years of undergrad, get a bachelor's degree, 4 years of medical school. Now, in medical school, your first 2 years are didactic, and then your last 2 years are clinical rotations, where you rotate through all the different specialties, and then you go on to your anesthesiology residency, and that is 4 years. And so to put it in perspective, I don't know the numbers. Probably somebody here can pull up, like, average hours and that sort of thing. But what I will tell you is that when I went through anesthesia residency, there was no 80-hour work week in effect. The legislature, a step up from all of us, has deemed 80 hours is the maximum amount that a training physician should spend in clinical care in the hospital. That was not the case when I was in residency.
Okay,
Do you know why residents are called residents?
Because they live there.
Because they live there, 100%. Yeah. So there's all of these different, pharmacies got a doctoral program, and when their students are going through that, they're calling them residents. Nurses who graduate from nursing school, before they go into whatever they're going into, they call them GNRs, graduate nurse residents. They've kind of taken this term resident, but it doesn't have the same meaning.
So the CRNAs do 2 years, and then do they do any clinicals or residency type?
So CRNAs go to nursing school, and that, depending on the route, is 2 to 4 years, but I think today, for the most part, it's pretty much 4 years to get a BSN. And then they go and they work in an ICU, and then, and they don't all go to work in an ICU. They can work in an ER or a PACU, but the lion's share work in an ICU. And then they go to CRNA school, which is about 27, 28 months, and then they graduate. So that 27 or 28 months is in the operating room working with either an anesthesiologist and a CRNA, or just a CRNA, depending.
Okay, thank you. I will agree with you what you said earlier about the second part of the bill seems to be the most worrisome or troublesome part of the piece of legislation that brings up raises some eyebrows of concern.
Yep.
I thank you for your time.
Thank you.
Thank you. Further questions for this witness? Seeing none, thank you very much for your time and
Thank you, sir.
And your testimony. Thank you, Doctor. Next up would be in favor of.
Thank you, guys. My name is Jacob Pilger. I'm the Chief Operating Officer of GI Associates and Columbia Endoscopy Center, located in Columbia, Missouri. I've worked in this capacity since 2016. Prior to, as of 2018, we transitioned from mixed use.
Sir, would you do me a favor? Can you check your light on the microphone?
Yeah, it's green.
Would you get closer to it? Yeah.
Sure thing.
Thank you very much.
Do you want me to start over, or?
Yeah, let's do that.
Okay, so my name is Jacob Pilger. I'm the Chief Operating Officer of GI Associates and Columbia Endoscopy Center out of Columbia, Missouri. I've worked in this capacity since 2016. Prior to 2018, our endoscopy center was a mixed-use anesthesiologist and CRNA model. As of 2018, we converted to a CRNA-only model, and from our experience, this model has basically proven uneventful, and we've made this decision really for 4 primary reasons. Efficiency, patient cost reduction, increased access for us to access anesthesia, and enhance operational flexibility. As a private practice, we constantly look for inefficiencies in a way to deliver care. In our CRNA-only model, it is clear that our CRNAs are more than capable of delivering the duties they have been trained, as well as able to do it kind of with just our physician oversight. After kind of reviewing the data that we've kind of looked at, our ASC has not seen any adverse events or anything that would be out of line from our mixed-use model under kind of moving to this CRNA-only model. And so when we couple this fact with kind of the increasing demand and shortages for anesthesia care providers in the state of Missouri, we feel that the kind of inefficiencies kind of speak for themselves, and we certainly are in support of passing this motion forward.
Are there any questions? Representative Stinnett.
To inquire.
Please proceed.
Can you tell me about the protocols that you have in place for your CRNAs?
Sure. So our physicians obviously sign all the anesthesia record, but our CRNAs, obviously we make sure that they have gone through all the appropriate training, certification, all of that. They do all the pre-op I guess, assessment, if you will. Our physicians follow them and do the exact same assessment. Then our physicians consult with them, sign off on the anesthetic record, anesthesia plan, and then they obviously deliver the care. And then kind of post-op, we obviously complete the full anesthesia note and record.
Okay, so currently you do have a physician overseeing all of that. So you were saying earlier you used to have
anesthesiologists.
Okay.
Yes.
And no adverse outcomes, but you still have physicians overseeing all of that.
Our GI proceduralist.
Okay.
provide that.
And what would be the difference then with this bill in place? It would just remove those physicians from needing to sign off on any of that.
Essentially, yeah.
Okay, thanks.
Other questions? Representative Dinkins,
To inquire.
please proceed.
Okay, you said you recently switched to only CRNAs?
In 2018.
2018,
I'm not sure how you
okay. And
define
so
recently.
what was your reasoning to switching to full?
Well, like I said, there were 4 reasons. Really, efficiency, because obviously anesthesia providers are not all that prevalent, and so you can gain efficiency by having CRNAs without having to have an anesthesiologist that are oftentimes needed in a hospital-based setting and not so much in an ASC setting. And then, like I said, increase access to those CRNAs, so kind of in that same vein. And then operational flexibility. It allows us to go directly to the person rendering the care instead of going to the anesthesiologist who might not be in the case at that time to ask what the CRNA.
So how much cheaper do you feel like this is by switching?
I mean, in reality, it probably doesn't really drive. It's not really a cost issue. In my sense, in my eyes, it was more about getting access to the anesthesia providers or the services that we need.
So the CRNAs make the same amount as the others?
We didn't employ the first one, so I can't speak to what their reimbursement was. I am certain as an anesthesiologist or anesthesia group, they probably have better contracts than a GI group does, so I'm sure it has reduced cost, but I can't speak to their contractual or revenue.
How much did this impact your malpractice premiums?
It didn't. We obviously disclosed all that. We talked it over with our malpractice carrier, and they basically said, it didn't adjust our risk at all.
Okay, thank you.
Further questions? Yes, Representative Roberts.
Thank you, Mr. Chair, to inquire.
Proceed.
So I've struggled with one piece of this pretty much from the beginning, and Representative Stinnett touched on it just before we broke for recess. This bill is going to allow a CRNA to select and issue orders for and administer controlled substances. And then it goes on to say the bill does not authorize the CRNA to prescribe the controlled substance. So we've had that question about the difference between selecting and prescribing from Representative Keithley. And then Representative Stinnett, I think, asked the question, if they're just selecting but not prescribing, whose DNA number applies? There's got to be a DEA number somewhere.
That's why our physicians sign it, because at the end of the day, I think the prescriptions pretty much run under our physicians, like our GI providers, I believe.
I just have to admit to you, I'm still just a little bit confused about this selection prescription distinction. And it would appear that in selecting that the CRNA is making this decision.
Right. So like, as I said, when we have a patient come in that presents, they come in, the anesthesia providers do the review, they establish a plan, they then consult our physicians who then review and say, we agree for the most part, unless there is some sort of deficiency or they have some sort of issue with it at hand. And then that's when they sign off on the record. So at that point, they're co-signing it. So they're DEA.
So the physician actually does then make a decision that this particular drug is okay for this particular patient.
I mean, for the most part, they're just relying on the CRNA's expertise. But yes, I mean, at the end of the day, they're signing their name on that record. So they're the
CRNA is making the decision.
I mean, they're working in collaboration with the CRNA, but yeah.
Okay, thank you, Mr. Chair.
Further questions, Representative Keithley.
To inquire.
Proceed.
If you're in a position where first of all, I guess I don't know that I understand still the effective difference if the physician still maintains the prescriptive power, but then the CRNA is administering, coming up with the order, presenting it to a physician. Not sure I understand the order, but my question is more so like what is the difference that this bill actually creates, and that is, has that physician actually visited, treated, seen? How much review of that patient that's being prescribed that has that physician who's ultimately signing off and doing the prescribing? How much interaction have they had with that patient?
So they have to go through their pre-op assessment as well, so they do that as well as kind of then oversee the anesthesia pre-op assessment as well. So they do both, so it actually kind of enhances, I mean, for us, we look at it as it enhances it, because then they get to dive in a little deeper into patient history that they might not normally know about, might not be brought up by the CRNA or the anesthesiologist in the current model. So for us, it actually gives them enhanced insight into what's actually happening, because then you're not as reliant on communication from.
Is the physician required to actually see the patient? Does there have to be a physician involved in the process right now beyond just signing off on the script and doing the actual?
I can only speak to what we do, which is yes. I mean, we certainly. I don't want to sit here and say yes, they have to, or legally they do. I don't have a legal degree. I haven't looked at that, but I know we have our physician to do that.
When the bill says select issue and orders, like I imagine those words are being chosen and changed because they're actually changing something in that procedural component between what happens between the CRNA and the physician in prescribing the medication. And I think ultimately, though, it doesn't change who prescribes it. So I'm trying to figure out, like, how much interaction is the doctor going to have? Does someone have just a standing script from a doctor? Can the doctor give out a standing script, and the CRNA is now has the power legally to just dole that out where it needs to go? Like, is that limited to a patient? Is it limited to other kinds of treatments? I read this and I don't understand what these bounds mean. I think it's the same thing that we've been asking about, and I
think that's probably going to be more interpreted kind of by each site and each facility, and they're going to kind of make their own independent decisions in all reality. I mean, that would be what I would think it would open up to.
So it'd be so independent sites would be free then to decide what their own procedure is going to be in their interactions between physician and CRNA.
I mean, that would be what I would believe.
So if a physician now the CRNA would have the ability then, if the physician says, okay, well, I'm just going to here's the prescription for what you need, and I'm just here to sign off on prescriptions, then they could work that out then in that kind of system.
I would think so.
Okay, thank you.
Other questions? Seeing none, thank you very much for your testimony. Next up will be in opposition to. And did you submit yours online, your testimony?
No, I have it here.
Okay, perfect. Thank you.
Thank you. Thank you for having me here. I really appreciate the opportunity. My name is Dr. Kathy Perryman, and I'm here today not only as a pediatric anesthesiologist, but as someone who began her career as a certified registered nurse anesthetist. It's from this unique vantage point that I urge you to reconsider House Bill 1561, because it's a bill that essentially grants CRNAs a medical degree and could compromise patient safety in ways that are profoundly consequential. I represent myself and the Missouri Society of Anesthesiologists. As I said, I have a unique perspective on this subject because before I became a physician and then an anesthesiologist, I was a nurse anesthetist in my early career. I decided to go to medical school and do a residency and fellowship, another 8 years total after CRNA school, because I recognized that I wanted and needed the additional education and training to gain the knowledge base and skills that I needed to be capable of safely caring for patients on my own. When I was a CRNA, I knew that I could practice safely only with the oversight of a physician who had those advanced skills and knowledge. Surgeons also have these advanced skills and should be kept in the position of supervisor of nurse anesthetists in rural practices to keep patients safe. Let me share a story that illustrates my concerns. When I was a CRNA, there were incidents of instability in my patients, like everyone's patients. And when that happened, I called for my supervising physician anesthesiologist, who immediately came and helped me manage and solve the problem. Once I had a patient's heart suddenly just stop for no apparent reason, I called the anesthesiologist, immediately came in and promptly treated the problem and saved the patient's life. It likewise, as the physician anesthesiologist, then for the next more than 3 decades, I was the one with the medical knowledge and experience and the skill set to address those problems immediately to prevent damage and possible death in the children that I cared for. Imagine if that physician wasn't there. What if it was your child or your family member? Wouldn't you want the person with the highest level of training and expertise ensuring the care of your family? These are situations where seconds count, and the depth of understanding that comes from medical school and residency and specialized training is invaluable. I've been involved with advocating for patient safety in Missouri since the late 1990s. Over these past decades, we have addressed the importance of physician-led anesthesia on multiple occasions when bills have been filed and heard in committee to loosen scope of practice for nurse anesthetists. 20 years ago, as one of the leaders of Missouri Society of Anesthesiologists, we met with Missouri Nurse Anesthetist Association, and we came to an agreement because we talked about what collaborative practice meant, and it meant that they had a certain number, up to 4 physicians they could collaborate with. And because that was a problem for them, especially in rural communities, and they wanted to not be required to have collaborative practice, we made an agreement with them that they wouldn't have to have collaborative practice agreements if they would agree to physician supervision ongoing, and they agreed to that.
Doctor, I apologize. Your 3 minutes. If you have something that's important to say and you won't take more than about 15, 30 seconds, I will allow that to happen if you think you need to say something more.
Okay, I think this is important. I deeply respect the skills and dedication of nurse anesthetists, but I really believe patient safety has to be the top priority. Thank you.
Thank you. Any questions for this witness? Seeing none, thank you very much, Doctor, for your time and your testimony.
Thank you very much.
We appreciate you being here. Next up for, excuse me.
All right, good afternoon. I submitted the witness form online.
Thank you.
My name is Denise Steit. I'm a CRNA in Kansas City, Missouri, and I'm here in support of 1561. Just to quickly summarize the main components of this bill, because I feel like we've talked about a lot of things today, but not really what the bill is actually doing. So one, it removes the requirement for supervision. It does not mandate supervision. Each facility can choose which model they would like to choose. It allows the CRNA to select, order, and administer, which I'm very looking forward to answering all the questions that were already proposed today, but to select, order, and administer the medication. So that just means immediately before, during, and after surgery. This will not allow us to prescribe in any manner. Those words were chosen by the Bureau of Narcotics, so that is why that was put in the language. Some testified today that there is no problem and nothing needs to be fixed. Though that doesn't necessarily surprise me because those they're not witnesses of the actual problem. So the CRNAs are the ones that are putting their license at risk every time that they are asked to care for patients. So just for some examples, when the supervisor is not always present during the anesthetic. So sometimes we give medicine before the surgery or immediately putting the patient to sleep for the surgery, waking them up in the recovery room. So these are instances where I am providing an anesthetic and yet there is no supervisor, or my colleagues in rural counties do not have the supervisor actually present. So the actual definition of supervision is not being followed. Requiring the CRNA, so the person that's in the OR and providing the anesthetic, to stop what they're doing and ask for page, text, call a supervisor to ask to give a medication doesn't help the patient and would delay patient care. So if I drop off a patient in the recovery room, the patient is experiencing some pain, I would if I wanted to be 100% compliant with the law, the patient is in the bed, grimacing in pain, I have to page the supervisor, who may or may not be consenting the next patient. I have to wait for the response, and then once they get back to me, explain the situation to the supervisor, and then give the medicine that I intended to give 10 minutes ago, but technically because of the law said I needed an order prior to administration of the substance. If I want to be compliant, that is what has to be done. So it's just there's no way that the CRNA can be 100% compliant and care for the patients without a delay. So those are the problems that this bill is trying to address. The other minor points, so we're not trying anything new. There is no supervision in the great majority of other states in this country. So the argument of worry of patient safety isn't there, because we're not seeing it in any other state. There are 24 other states that have completely removed supervision. All of the ones that have removed supervision completely still do not have the requirement for supervision. So I think that should speak for itself. I want to leave some time for questions, but I just ask that you support House Bill 1561, essentially just allowing the CRNA to take off the handcuffs, provide patient care as we've been trained to do so. Thank you.
Thank you very much. Yes, Representative Dahl. Proceed.
Good afternoon. Thank you for being here. So is it your impression or your understanding, because you obviously know the answer to this, that technically, according to Missouri law currently, you should not be able to put the person to sleep or be with them when they wake up without a physician present?
Yeah, supervision itself is not defined in the current state law, so it's up for interpretation, and facilities will define that differently. Sometimes, depending on how they bill the anesthetic, will determine the level of supervision. So it's widely interpreted.
Okay. But so in theory, if we were to follow the letter of the law, then we would need physicians to be there from the time the patient enters the OR until they leave.
Yeah, especially with the Bureau of Narcotics interpretation, that the order for certain medications needs to be obtained prior to the administration. So I think that's a lot of where we see this gray area where medicine is being given or maybe being given, but that order was not obtained or the protocol was not signed. Now it's being done later. The protocols are signed, everything is okay before billing. But to do that to the extent that the Bureau requires is not possible without delaying patient care.
Right, so maybe we should start requiring physicians to be there from the minute the patient is taken back until they are ready to go back to the recovery room.
I suppose that's an option. That's in the states that have removed the requirement for supervision, and honestly, some that still have the requirement for supervision, that is not required. It's the anesthesia provider's job, whoever the anesthesia provider is, to usually put the patient to sleep, and then the surgeon will come in and do the surgery, and then they leave and you wake up.
Right, and I'm being facetious because I don't think we have any doctors that are really going to agree to that because they want to hop from room to room to room and do their cases quickly.
Sure.
But I think you can't have it both ways. Either you follow the letter of the law or you don't. So
Yes, especially like in OB situations. So if I get called to place an epidural at 2 a.m., I place the epidural with the OB nurse, and if the obstetrician is the supervisor, then they would come in later that morning when the mom is further dilated and closer to delivery, and then they're signing the protocol or signing the chart. So it's a roundabout way. We're making sure that patients are taken care of, but not always to the degree that the law is interpreted by some.
Understood. Thank you.
Thank you. Representative Keithley.
To inquire.
Proceed.
I would, in a situation like laid out with we'll take 10 minutes to delay too. I mean, we've heard that there's clearly a diverse set of circumstances under which, some hospitals have zero anesthesiologists to some. No, I'm assuming the hospitals can develop their own protocols right now to try to alleviate that delay right now, right?
Some have and some have not. I think that the requirement for the protocol is severely lacking. The last communication was from the Missouri Hospital Association in the end of 2017, beginning of 2018. And so a lot has happened since then. So those that are still practicing with the protocol, they're they're making it work, but there are facilities that still do not know of the requirement for the protocol.
So the thing about the situation you gave, where the patient's in pain and we need to find some new I mean, it would have to be, for this bill to even make a difference in that case, it would have to be an existing prescription that patient already has.
Yeah, so just to the point of the prescription, so if I am within a facility and I'm getting the medication from that facility, a hospital, for example, then that's not a prescription. It would be an order. So that is the language, again, that was given by the Bureau of Narcotics. We didn't create that. But so if it happens within the facility, that's the order. And then a prescription would be something that the patient is sent home with, and then the patient would get from a pharmacy.
What is the bounds of facility? Are we only talking about hospital, or are we talking about other types of clinics?
Yep. So just according to the current statutes of healthcare facilities would include ambulatory surgery centers or hospitals.
Okay. So now I'm starting to understand what orders mean. Like the prescription is what they go home with to take the medicine so you can give it to the patient.
Yes.
But exactly. The order is what a CRNA can do without a physician ever signing off on it at any point.
In the 49 other states, yes. In Missouri, we have to get the order before we give the medication.
But you still would not be able to give a brand new medication, even with this bill, you would not be able to give a brand new medication to that patient, even with this bill in place.
If I'm giving it in accordance with a surgery or procedure, yes. I as a CRNA, if I'm requested to do an anesthesia case, then I give the medication that the patient needs for the surgery or procedure. But I'm not sending them home with anything. It's just the requirements that the patient needs so they can be safe and comfortable for the surgery or procedure.
So right now, a physician has to sign off on it regardless of how it works. If a CRNA is in a hospital, is in another kind of clinic, there has to be a physician somewhere signing off on this medication is being administered to this. I know the physician doesn't have to administer the medication right now.
Sure.
There's no delay there. A CRNA can do that. But a physician is signing off on that no matter what type of facility we're in right now, right?
Yes, and if there's the differentiation, it's a whole nother topic about the ketamine and pain clinics. So this is only in relation to in the facility, ambulatory surgery center, hospital, or such. That yes, the controlled substance requires an order from a supervisor, dentist, podiatrist, or physician.
But if we change this because you no longer need a physician to do the orders, if we're in another kind of facility, now we can operate, like a CRNA would be able to operate that facility independent of a physician.
So when you say operate a facility, so it would be a hospital or an ambulatory surgery center or a building that a procedure or a surgery is happening, then yes, the CRNA can give the medication as the patient needs.
Does this bill limit to just a hospital setting where we would have a physician in? Because
yes,
I don't see that part where it's limited.
Yeah, absolutely. So the end of the bill, pages 11 and 12, I believe, or 10 and 11, that talk about the pain and the ketamine clinics. I know that's been a high point of contention so far. So that was added in at the request of last year's bill because prior to that being added in, it was left open for interpretation. So as means of compromise and to not try and be deceiving anyone, we added that language so it would very clearly say this is what the CRNA may or may not do. And as a further method of compromise, we added in language to say if they want to do it, they have to work under collaboration or under supervision. So that if the CRNA wants to give pain in those settings, infusion or for chronic pain management, with this new bill, they would still need to work in follow the collaboration rules or the supervision rules, however is set forth by the law.
But like collaboration, we've dealt that with in the APRN language. Collaboration is very different than the supervision language we have right now, right?
Absolutely.
Collaboration, I mean, that physician could never see that patient. That physician could never not be in that area. Could not be a part of that at all. So, I mean, and that's what I mean by saying the CRNA is essentially operating that practice completely independently of a physician being able to. And that's what I'm getting at with, like, you know, we're dancing around prescription but doing all these other things. And at that point, aren't we just saying, like, isn't it just simpler just to say, like, what I feel like we're really doing is just letting the CRNA prescribe this stuff to the patient, not just administer it. They are making the entire treatment plan and going through it all. All we're doing right now, the way this bill is written, looks like I'm not sure who the doctor is who's prescribing it, because the doctor may not be on site, may not even, if it's just collaboration, I really don't know what that doctor's role is in that facility at all once we go past the operating room.
So with regard to the prescription again, so if they want to prescribe anything in the ketamine or pain clinics, they still have to follow the rules that are set forth for anyone that wants to prescribe. So that would include getting the certificate from the nursing, going through the so many preceptor hours of the training. And so there's multiple steps that are required in Missouri if a nurse practitioner or advanced practice nurse wants to prescribe. So if the CRNA wanted to do that as part of their clinic, then they could undergo that training and work with their collaborator and do that with them. The great majority of anesthetics for CRNAs are happening in hospitals, surgery centers, and that does not involve prescription. It's just, you need anxiety medicine for a surgery, I'm going to give you anxiety medicine. You need pain medicine, I'm going to give you pain medicine.
Okay. All right. I appreciate it. Thank you.
Okay, thank you.
Thank you. Further questions? Seeing none, thank you very much for your testimony. We appreciate you being here. Next up in opposition.
Afternoon. My name's Dr. Quinn Johnson. I'm an anesthesiologist. I currently practice in Columbia, Missouri, but I've also practiced for 7 years in Joplin and practiced for 20 years here in Missouri. As many of you have already, we've clearly identified that while elements of this bill, there's a lot of similarities to bills that have been submitted in the past. The most crucial one is the new provision dealing with the infusion centers. These are new businesses that are popping up across all the nation. It's not just here in Missouri, but we certainly are facing new infusion centers happening. And a lot of times they're advertising for a variety of treatments. One from Columbia, Missouri that I'm fully familiar with on their website indicates that they're willing to treat for hangovers, jet lag, reverse aging, and for cold and flu symptoms. But also, they're willing to treat you for your chronic pain. So it's kind of a catch-all, I guess. And that chronic pain is where they specifically identify chronic pain, depression, and migraines. And the medication that they're advertising that they'll do those chronic pain treatments is ketamine. And I think that's been discussed quite a bit earlier by people that were testifying previous to me. But the use of ketamine for chronic pain treatment is an off-label use, and it falls into a very gray area of treatment. While there certainly are some areas that chronic pain physicians can use it, currently in the setting that this is being proposed to do it is often in a setting that's like a strip mall or some business that's not involved in a hospital for your infusion center. Currently, the question of ketamine, as I handed out, is drawing attention to the FDA, and there's a great deal of questions of the legality of kind of what's happening with ketamine in this setting. So currently, this requirement is that there has to be a physician on site and to help prescribe the medication that's going to be delivered in an infusion center. If this bill goes through, that's eliminated. The physician would not have to be on site. They could be in a collaborative agreement, and that physician does not have to be present. So I'm very familiar with this because I had 2 of my CRNAs leave my group to set up this infusion center that we found in Columbia. I assume they're among the 5 that were referenced earlier that are treating chronic pain. I'm not 100% sure. But the question that we have is currently is originally they had a physician a general surgeon that they were collaborating with that provided the DEA oversight. But currently we don't know who that is. And I think the oversight and the concern that we have that's been expressed repeatedly is that's just going to be removed. And the concern would be more and more of these things popping up.
Thank you very much, Doctor. Any questions for this witness? Seeing none, you're getting off easy. Thank you very much. We appreciate your testimony.
Good evening, Mr. Chairman, members of the committee.
How are you, sir?
Chris Ropey here on behalf of the Missouri Association of Nurse Anesthetists. I think we've talked about a lot of things today that have nothing to do with this bill, which is probably beneficial if you are opposed to this bill and would like to see it not go forward. If the references to the bill about ketamine pain, we will gladly remove that from the bill. Those are simply added to prohibit the concerns raised during last year's hearing about potentially independent practice, and gladly take those out of the bill if that is the concern, because that is not what we are getting at. I think the history of supervision is important to understand. It came about as an administrative billing issue, nothing to do with safety. I believe physician anesthesiologists were not on site while CRNAs were delivering anesthesia, and you had a lot of Medicare fraud issues that were cracked down on, and so the requirement to be on site was implemented in order to avoid that, and then went through the decade of the 90s, and everything seemed to work just fine with CRNAs in places where there was not supervision. You have 43 other states, whether it's in their laws, their rules, their regs, their nursing codes, whatever the case might be, does not require supervision. You can look at medical malpractice rates. It is not a safety issue. That is the boogeyman that people want to point to, but money talks, and rates are the same in states with or without supervision. The solution on the Bureau of Narcotics and Dangerous Drugs to just simply have protocols in place does not work, and there is no guarantee that it works 100% of the time. You can look at the letter from BNDD that I've seen a copy of that says, all you got to do is have the protocols in place. But if you have to go outside the protocols, then you just have to go get verbal permission. So like Ms. Stite said, you could run into plenty of scenarios where the surgeon has already left. They're down the hallway prepping for the next case. Something goes bad with the anesthesia, and you've got to do something. If you follow the law in the way that Missouri is the only state that interprets this way, you're asking the CRNA to choose between the patient's safety or practicing outside their license, violating the law the way that BNDD interprets it. That is not fair to our CRNAs to put them in that position. Look at the zip codes, look at the towns of the physician anesthesiologists that were here to testify. They are not out in those rural settings. It works just fine in many other states. You heard from the CEOs of some of these smaller rural hospitals. They need this change, and they need this tool to be able to make sure they can keep up and be able to deliver health care for their communities, and would really encourage you to support this bill. And happy to visit offline with anybody who wants to ask as many questions as the committee has, since we're limited to 3 minutes here.
Thank you, sir. Any questions for this witness? Seeing, whoop. Yeah. Representative Lewis.
Thanks.
Proceed.
Good afternoon. Thank you for that. And I think, you and I have had conversations with the bill sponsor and various stakeholders. I'm glad you brought up I think you touched on protocols a little bit, but my understanding is, the protocol thing the adoption rate is unknown. I tried to get some numbers of hospitals, that have the protocols, and that information was unavailable.
Nobody has any clue which facilities do or don't, and you can try to stay on top of it as much as you possibly can. You cannot guarantee that every facility, hospital, et cetera, has them. You can't guarantee that you never have to go outside of them, and then you are putting that in jeopardy. And there are instances where people want to say, oh, it's an enforcement issue. There are instances where up the Macon Hospital, a CRNA got written up because of this interpretation. Billing requirements, it wasn't done right because of this interpretation. Recently, I think down in Cape Girardeau, they are now making them, I believe, their surgeons have to get anesthesia training to now sign off on them. We've heard from folks who talk and have to work and recruit surgeons, and they know that's not something they want to do. They don't want to sign off on somebody's work that they admit they don't know anything about.
Right.
We hear that all the time.
Yep. And I think we had some surgeons testify last year about that exact. Didn't want to, and I wouldn't want to sign off on anyone else's work as well. And then the other thing I was going to comment about. Sorry, I forgot my thought. I'm in Kansas City, and I've had some of my healthcare systems reach out to me about this bill, and I've said, nothing will change for you. You can adopt your own policies that work for today. Like if you want anesthesiologists, involvement, whatever, this will do nothing. It's more to help, like you said, the rural hospitals.
We tried very hard to craft this to address those concerns, and specifically wrote into the bill that nothing in this section shall be construed to exempt a certified registered nurse anesthetist from complying with a healthcare facility's policies, protocols, standing orders, or staff bylaws for the provision of anesthesia care. So if the facility wants to have protocols in place, they want to keep supervision in place, they want to make you jump on one foot,
right,
they can do any of those things that they choose to, and require their CRNAs to follow that. But in a lot of these rural settings, it's not working, and it needs to be fixed.
Yep, agree. And I certainly wouldn't want to get, sideways with the healthcare systems in my community that, that service our area. And I think that's really important, and why I also have the bill sponsor, because it is helping the rural communities, and you can tell by the administrators who spoke, I can just see their fear of their doors being closed, so anyway. And
you're speaking of some of those systems, I've spoken with several CEOs that say we are in the big urban hospitals where many of the witnesses who are against the bill are from, have flat out said, we're not going to change the model that we use and how we do it. So, for folks to want to stop others in the name of whatever reason just doesn't make any sense.
Right. Yeah, very good point. Well, thank you very much. Thank you, Mr. Chair.
Thank you. Representative Dinkins.
To inquire.
Proceed.
So you said it was mainly for billing issues, the reason why and so I'm still wondering why anybody would want to be an anesthesiologist. I mean, why wouldn't they just go this other route?
I don't know what to tell you.
Okay, so basically it seems
in
like
reality,
in order to get more, we just need to do CRNAs at the 2-year or 2 to 4 year and do away with the anesthesiologist program.
No, I think I just mentioned, if you talk to a lot of the large urban hospitals, I think there'll be a great need for physician anesthesiologists there. They have said to me they aren't changing the model that they use.
So why do they want to? I just don't understand. Why are they wanting to keep that model?
You'd have to ask them. I don't know.
Okay. So did I hear you say this was your bill and we changed this?
Pardon?
Is this your bill?
We are supportive of the bill,
okay,
yes.
because you said we changed it from last year.
Yes.
But you don't know why the anesthesiologists, why the big hospitals want to keep them?
Why they want to keep physician anesthesiologists?
To keep their model.
I don't know.
Okay, thank you.
Thank you. Any further questions? Seeing none, thank you very much.
Mr. Chairman, if I could, Todd Ahrens was here, but he had to leave since the committee got delayed. Could I leave his testimony?
Yes, please.
Thank you. He's the CEO of Hannibal Hospital.
Yes.
Thanks.
I think we were missing that one. Thank you. Anybody else here opposing this bill?
that would be why. Now you can hear me. My name is Julie Marshall. I'm an anesthesiologist. I have been practicing in Missouri for 15 years, and I am here in opposition to the bill. I don't want to hit on a lot of items that you guys have already heard testimony on, so I was trying to maybe find some areas that I can add some insight to. I have had some leadership roles. I was prior Missouri Society of Anesthesiologists president. For the issue of having the protocols in access areas that may not currently have protocols, I will say that we have helped or asked to help identify those areas in the past and try to link them up or provide protocols that other institutions have used if that is a need. And I am going to step out on a limb without talking to my group and saying that I think that that is still something that we would be willing to assist with if there are places that feel like they are not in compliance but need a protocol. I have seen some of these protocols. They are very broad. The amount of medication that can be given on the ones that I saw were, decent doses of medications. Ones where if somebody was providing more than that, I would hope that there would be some discussion with the proceduralist to say, why is this patient not, responding, or maybe if there is a complication with a surgery, that there is additional discussion going on about what is going on with that patient, and having that requirement in place, I think, is a safety item. For the, the main issue, I think what we need to think about in what we're doing for this bill is a safety thing. And I think if we're going to be changing healthcare in Missouri, patient safety needs to be the utmost question. I haven't heard a lot of discussion about how this improves safety for patients in Missouri. And then lastly, when we're talking about why would somebody want to go into medicine or go into being an anesthesiologist, and what that looks like, I feel like my medical depth of knowledge has, been increased through medical school, through the long years of residency training. I train residents, I train medical students. This is a very in-depth process with ongoing testing, oversight, and I think that it provides the best patient care.
Very good. Questions for this witness? Seeing none, thank you very much for your time and your testimony. Next up, in opposition to. I apologize. I think we should be going in favor of. Is there anybody here in favor of? Anybody left? Okay. So opposition.
Thank you, Mr. Chairman, members of the committee. I know it's been a long day. David Jackson, registered lobbyist for Jefferson City Medical Group, as well as the Missouri Society of Anesthesiologists. I know the bill sponsor referenced earlier, this was the CRNA Freedom Act. I would suggest an amended title of the CRNA Ketamine and Wellness Center Authorization Act. But I, in all seriousness, want to go back and just tie up some loose ends and address some of the questions here, and I think perception on what we think this bill does. There's been a lot of talk about this being in hospitals versus outpatient, urban versus rural. If you read this bill, there's no language in there that specifies this is inpatient hospital versus outpatient. It doesn't make any distinction versus urban versus rural. In the issue of prescription versus administration, that's really the crux of this whole discussion. So when you go and you have surgery, it takes a cocktail of drugs to knock you out, to make sure you don't feel anything while someone's operating on you. Those are highly controlled substances. So those have to be ordered and prescribed by somebody with the DEA number. We always think about a prescription as something you take and piece of paper you take to Walgreens, right? But whenever a surgeon is doing an open heart surgery and they issue those controlled substances, that has to get processed as a claim in the pharmacy hospital or a surgery center and can't come out unless there's a DEA number attached to it. And so when an anesthesiologist is there in a lot of your urban hospitals, They're the ones helping create that anesthesia care plan, and it's under their DEA number. In a rural setting where you don't have an anesthesiologist, that surgeon is the supervisor of record, which means that that order for controlled substances is coming under their DEA number. Now, we've heard conversation about, well, that surgeon doesn't want to be interrupted. I want to be clear, there is a blatant misrepresentation of the Bureau of Narcotic and Dangerous Drugs, BNDD, which is our mini DEA in our state, and their interpretation on this. We have on their letterhead here saying, can a CRNA administer controlled substances without having to interrupt the physician? And they said, quote, yes, a doctor does not have to give an order every single time. Facilities can develop protocols that nurses can follow that give them drug names, situations, dosing levels, and limits. So for that surgeon that has anxiety about that, the facility can work with the professionals to set those bumpers and guidelines. And so in that patient's chart, it says that those are prescribed pursuant to the facility's protocols. When we brought this up with the CRNAs in a meeting last week, they said that they'd never seen the protocols. I will advise you that they helped write the protocols over 10 years ago with our association and with the hospital association. We've got a copy of them here on the record. And lastly, we have given different language, or we've given language to the bill sponsor that requires the hospitals and surgery centers to implement those protocols, provided that nothing is allowing for the administration of controlled substances for ketamine or any of these infusion therapy clinics. Am I up here on time? Okay.
You're up. Sorry.
I will stop there and answer any questions.
All right. Questions? Yes, Representative Dahl. Proceed.
Good afternoon.
Hello.
Representative, can you move your phone away? There you go. Thank you.
So help me understand. I understand that in the urban setting, right? And I also don't think that a CRNA wants to be running on open heart surgery, right? I think they're working in GI clinics, places like that, whatever. But in a rural setting, let's say that the attending doctor, the ordering physician, is a podiatrist. Is that podiatrist writing this protocol?
Right now, that podiatrist, if they have the prescriptive authority and are authorized to supervise there, then that drug order would go under their DEA number, and they would be the supervising provider on record, yes.
So then that podiatrist would tell the CRNA, these are the drugs I want you to give this patient?
Ideally, in that scenario, the CRNA would put together the anesthesia care plan, probably in that either podiatrist would sign off on it or the facility would have a protocol in place.
Because it seems like a double standard that in those settings we're trusting the CRNA to create a plan, but in other settings we're saying, no, you're not, you need to follow our protocol.
All we're saying is that if you don't have a physician anesthesiologist there needs to be a protocol in place to make sure whoever is administering the controlled substances, it has to be under somebody's DEA number. I think as Representative Stinnett asked earlier, this has to trace back to somebody's DEA number. And so what this bill does is say that a CRNA can administer controlled substances without a DEA number and without a license from the Bureau of Narcotic and Dangerous Drugs and without any physician or anyone with a DEA number approving it. And what that means is that the most powerful thing we've heard today is that 5 CRNAs are doing pain management, if you heard that earlier. So what this means is that they can run those pain clinics right now and those ketamine clinics without a physician on staff, without a physician on site, and push ketamine. They could push. There's nothing in this would prohibit, fentanyl, propofol, without anyone with a DEA number signing off on it.
But you said they're already doing it. So how are they currently doing it?
That's a very good question. We have no idea how they're doing it right now. When this says that this bill doesn't authorize anything new, not already doing it, I would question why the last 2 pages of this bill are all bolded black lettering authorizing a CRNA to enter into a collaborative practice with a physician to run these pain clinics and infusion centers, because there's nothing in current law that authorizes that. And we have no idea whose DEA number those are currently being administered under.
I understand. I would just say that the scariest thing I've heard today is that we have people in rural hospitals like podiatrists that are running or allegedly instructing CRNAs what to do. Because I got to tell you, I'd much rather have a CRNA putting me to sleep than a podiatrist or a whatever.
Well, and I think, look, I think the CRNA is going to be trusted in that scenario. All this is saying is that the protocol establishes basically the prescription for that order. And so it sets those parameters. And that podiatrist probably isn't setting that. You know, they may be involved in that, but you probably have, I mean, the guidelines and sample protocols were jointly promulgated through the Missouri Society of Anesthesiologists, the Missouri Association of Nurse Anesthetists, as well as the Missouri Hospital Association that facilities could adopt to set those boundaries basically in guidelines for them. And I would assume that is a very small fraction of surgeries where you have a podiatrist as a supervisor on record. But in that case, that's why those protocols are there, because that podiatrist may not be as comfortable with it. But it at least ensures that some people who are, and somebody with a DEA number is involved in saying, hey, if this is going to be administered under my DEA number, we're going to set some boundaries here. And that's the whole purpose of the protocols.
Okay, last question, because I feel like I'm getting conflicting information. Does every hospital in Missouri with an operating room that's administering anesthesia have a protocol in place, or do they not have a protocol?
It's a very good question. So in most hospitals, as I understand, that have a physician anesthesiologist, you won't need a protocol in place if they're the ones creating that care plan in that order. In rural hospitals, whenever the nurse anesthetist went to the Board of Healing Arts or the Bureau of Narcotic and Dangerous Drugs and said, hey, we're administering, we're not prescribing, they said, no, you don't have prescriptive authority, but if you have a protocol in place, then you can administer those medications. When in our meeting last week, when they said, well, there's some hospitals not doing it, our answer was enforce the law. I mean, there's laws right now that say they have to have these protocols. If you have people that are administering controlled substances like ketamine, propofol, fentanyl, without protocols, that's illegal.
But we don't have any standards for who's writing those protocols. Is that true?
We don't, but we have offered language to the bill sponsor that requires every hospital and every surgery center to have protocols.
Okay, thank you.
Representative Dinkins.
To inquire.
Proceed.
Okay, I think you may have answered my question when I've been asking, why is anybody going to want to be an anesthesiologist? And you said earlier that the DEA number has to be tied to someone. So the anesthesiologist has a DEA number?
Correct.
And then the what are we talking about here? The CRNAs do not?
Correct.
And
they
then
do not have prescriptive authority.
Okay, and then all doctors have the DEA.
Correct. If they're prescribing medicine, controlled substances, yes.
Okay.
So they go and they apply for a certificate of controlled substance with the Board of Healing Arts and the Bureau of Narcotic and Dangerous Drugs, and then they're issued a DEA number from there. Okay.
I would say that a podiatrist is a probably pretty small number in the state. And I'm also going to say, coming from a rural community of 7 counties, that I'm not going to say any rural county probably ever has a podiatrist. We are lucky to get regular physicians, so they're really not going to be specialized physicians. They're going to be general physicians that have more of a broad scope. Okay. Thank you.
Thank you. Yes, Representative, what's your name? Proceed. You got to have some fun, right?
Yeah. Keep us awake. Good afternoon.
Good afternoon.
Thank you very much for good evening. You're right. It's 5:10. Jeez. Okay, so I just want to kind of clarify a couple of things. The meeting last week, I was there.
Yep.
And I just want to clarify what I thought I heard you say, that the CRNAs said they didn't know about the protocols, but you had them sign off on it. You've had their signatures.
So whenever the protocol issue came up 15 years ago, there were sample protocols that were put together as guidelines that the Missouri Society of Anesthesiologists, the Missouri Association of Nurse Anesthetists, and the Missouri Hospital Association all worked together on to send out to all their facilities to say, here are, if you don't have an anesthesiologist and you want some guidelines, here are some ones you can use as a template, and you can make them your own.
Yep. Okay, but in 2017, 2018, when these protocols were written, CRNAs were at the table, according to you. But I just think it's a little disingenuous to speak that the CRNA that was at our meeting last week she works in rural hospitals, and the rural hospitals that she works in, they don't have the protocols. So she is currently practicing in facilities where these protocols are not adopted. So I just want to clear up that, these people who came to the meeting yesterday, or last week, that they weren't.
So she had mentioned she previously worked at a hospital and they did not want to have protocols, or that they kind of blew it off, which is why we prepared language saying that hospitals and surgery centers should have to have them. We have no excuse. If somebody doesn't have a protocol and they don't want to operate under that protocol, they shouldn't be administering medications authorized by the DEA. That is our opinion. Secondly, that CRNA, I don't believe, works in those hospitals anymore. That CRNA owns a ketamine clinic.
Okay, I don't know about that. But then back to the DEA number. To the ketamine clinic. The lead sponsor over there, or lobbyist for the group, said they're happy to get rid of those language referring to ketamine clinics and infusion clinics.
So I think there's some misrepresentation of what that language does. What the beginning of this bill does is authorize a CRNA to administer controlled substances without a DEA number, without a BNDD number, without a physician supervising, and without anybody signing off on that order. So therefore, right now, if you're operating a ketamine clinic, the big question is, whose DEA number is that under? If you see a social media ad online...
But he said he would get rid of that language that they added that from the hearing last year. So would you be okay with...
Would you mind if I finish my... So right now, under current law, it's very gray, right? So if you have a ketamine clinic right now that's operating,
right?
The question is, whose DEA number is that under? Our assumption is, based off the current law, they should have a physician on site there directly supervising, making that happen. Whose DEA number that's under. Under this bill, even with that language out, under the first part of the bill, authorizing a CRNA to administer a controlled substance without a BNDD number, that would mean that a physician, they could be ordering those without a physician on site under that physician's DEA number. So you have we're trying to police our own in this. This is going to prevent a doctor from making passive income sitting as the medical director of a ketamine clinic without ever having to be there. That's what this does.
Okay, and then it's my understanding that CRNAs do practice under the hospital DEA. So,
if you can point to me where in the bill this talks about hospitals, I mean, there's nothing that specifies hospitals.
You're the one talking about DEA.
Right, so my question is, if you have a ketamine clinic, whose DEA number is that being prescribed under?
Well, we can strip that language altogether and just leave it gray like it is today.
Under current law right now, who's it under?
Right, exactly. So it's gray today. This was just trying to address some concerns from the hearing last year, and we can scratch everything about ketamine and infusion clinics and just leave it gray like it is today.
I think maybe we agree to disagree on this, that even with that language scrapped, our issue is in page 2, lines 21 through 34, where it allows a CRNA to administer a controlled substance without a DEA number and without a certificate of controlled substance.
That's the BNDD fix that we talked about last week.
Which would allow a ketamine clinic to operate without a physician on site.
Okay, all right.
I mean...
Thank you.
Further questions? Seeing none, thank you for your testimony. Next up in support. No, I'm sorry, no support. In opposition.
Thank you, Mr. Chairman, members of the committee. Jeff Howell. Today I represent the Missouri State Orthopedic Association, Missouri Society of Gastroenterology. I've been through a lot of these hearings, and I sometimes use the same testimony that when and Representative Dinkins has talked about this, and Representative Roberts took a swing at it, when we take two professions and we disregard their didactic education, their clinical hours, their experience, and their training, and we make them the same, one of them inevitably becomes unnecessary. And the decision of who becomes unnecessary is not made here. It's a business decision, and it's not a healthcare decision. So there's been lots of talk about protocols and prescribing and ketamine clinics. What I'm really concerned about is that 4 years of medical school and 7 years of an anesthesiology residency mean something. They've got to mean something. So I urge you to be cautious as you move forward with this bill. Thank you.
Yes, Representative Dinkins.
To inquire.
Proceed.
Okay, let's go back to the DEA number. Still trying to get all this straight. And I just heard the lady mention about a hospital's DEA numbers. Do hospitals or facilities have DEA numbers?
They can, as far as I'm no expert on this. They can in some states. I know in Ohio, they passed a bill a few years ago, and CRNAs can use the hospital's DEA number in Ohio.
Okay, why would they be able to have in certain states? Isn't DEA federal?
Yeah, it is, correct.
Okay, so, I mean, when I'm kind of looking it up, I didn't see where any facilities are listed, but only providers such as physicians and physician's assistants. So maybe someone else can provide that to me later.
Yeah.
All right, thank you.
Mm-hmm.
Other questions? Seeing none, thank you for your testimony. Next up, in opposition. Can you make sure your mic is turned on, Doc?
Off. Okay. Joyce Ruza from St. Louis. And I'm actually want to make a very brief comment because this question was raised about hospital DEA numbers. And what it is that some hospitals have DEA numbers for their training programs. So residents do not have actual license and they don't have a DEA number. They work under the hospital DEA number. However, everybody else, all other independent providers, physicians, have to have their own DEA number. Thank you.
Questions for this witness? I want to ask, if they do have a DEA number already assigned to the hospital and it's being used for the residents, or could they still use that? Could it be also used for the CRNAs?
So that might be beyond my expertise, so I don't want to speak out of turn on that.
Thank you.
Thank you.
Okay, next up for opposition.
Mr. Chairman, members of the committee, Nikki Strong here on behalf of Reyes Radiology. We have 9 imaging centers, outpatient imaging centers in the St. Louis area. This would impact us in the interventional radiology procedures that we do for chronic pain management. I've submitted a our testimony to your office, and it talks about some certain procedures that this would be. So we are in opposition.
Very good, thank you. Any questions for this witness? Seeing none, thank you very much. Next up, opposition.
Mr. Chairman, members of the committee, Jorgen Schlemmer on behalf of the Missouri College of Emergency Physicians to also go on record in opposition.
Any questions for this witness? Seeing none, thank you for your testimony. Any further witnesses in opposition? Seeing none, any witnesses here to give us informational purposes only? Seeing none, guess what, guys? That concludes this hearing. Thank you very much for your patience and staying for us through the session.